topic for today's discussion is the basic science of movement disorders, and we'll be covering it under the following sections. So, first, we'll have a very brief and very simple discussion on basal ganglia physiology, and then we'll move on to an overview of movement disorders, and then we'll discuss about how surgical interventions for movement disorders work and what should we know about these surgical interventions. So first, let's discuss the basal ganglia physiology. Right. So what exactly are the basal ganglia? So this is just very simple standard neuroanatomy. There's a group of nuclei at the base of the brain, but there are just so many, and they're classified in multiple different schemes. So one way of classifying them is as follows. So you can classify them into different parts of the striatum. So there's a dorsal striatum and a ventral striatum. And the dorsal striatum usually includes a chorion and putamen. And the ventral striatum includes two nuclei, which will not be really important for us in this discussion. So the nucleus accumbens and the olfactory tubercle. There is a separate part of the basal ganglia known as the pallidum that includes an externa and an interna. So there's a globus pallidus externa and interna. There's a subthalamic nucleus located below the thalamus. It will not be in the area of the basal ganglia per se. And then there's a substantia nigra, which is located in the brainstem, in the midbrain, also not in the location of the basal ganglia. So that has two different parts, and that is a compacta and the reticulata, which are located, as I said, in the midbrain. So the compacta is actually dopaminergic, and the reticulata is GABAergic, and we'll see in more detail later as to why that is important. So when we discuss the basal ganglia physiology, it can be very complicated if you just look at it overall. Like this, these are multiple images which describe and depict what the basal ganglia do, and it is complicated. Like there's a lot of different connections that the basal ganglia form with the cortex, with the thalamus, with the brainstem, and this can make it look like it's just impossible to understand. So just ignore all of this, okay? And if you like I said, it can get very complicated. So just ignore all of it. What does it actually boil down to? That's all we really want to know. Like what should we focus on? So there are different parts of these circuits, okay, and the important parts are the cortex, the basal ganglia itself, the thalamus, and the cerebellum. Okay, so there's four different parts to this circuit. Okay, and as I said, cortex, basal ganglia, thalamus, and the cerebellum. Now, within the basal ganglia, the important structures are the striatum. So you can forget about the caudate, the putamen, and all of those subsections of the striatum. Just remember the striatum. Apart from that, you have to remember the globus pallidus externa, the subthalamic nucleus, and the globus pallidus interna and the substantia nigra pars reticulata. Okay, so to again, what does it actually boil down to? The input structure of the basal ganglia is the striatum. The striatum is what is going to receive the input for the entire basal ganglia here. And the output structure of the basal ganglia is the GPI SNR. Okay, if there are any comments, just put them in the chat box. I'm not sure if
Sir, we cannot see your screen.
I hold on. Is that a problem that everybody is having? Because I feel like it can be seen. If anybody else can let me know in the chat box if the screen is seen or not, I will just work on that. Okay, so I think that might just be a problem for you because other people are saying that they can see the screen. I think you might just want to restart the application. Okay, so I'll continue. As I was saying, the input structure for the basal ganglia is a striatum, and the output structure for the basal ganglia is the GPI SNR. Okay, so just think of the GPI SNR as one structure, and that outputs all the basal ganglia output to the thalamus. Okay, in between you have the other nuclei. You have the GPE, the STN, and the SNC, which is the pars compacta. Okay, so these are structures which are going to come in between the striatum and the output nuclei, right? So again, from the cortex to the striatum, the basal ganglia does all the work. After that, it outputs through the GPI SNR to the thalamus, right? So that those are the important things to remember, and we'll discuss more as to what is happening within the basal ganglia as we go on. So importantly, what should you know? The input nuclei are the striatum, and sometimes in one particular case, if you're using the hyperdirect pathway, the input nucleus can be the subthalamic nucleus. The output nuclei, as we discussed, is the GPI SNR. Okay, so again, there is a direct pathway and there's an indirect pathway. So that's a little bit more complicated, but it is still straightforward to remember. So from the cortex, ultimately you have to reach the output nucleus, which is the GPI SNR. There are multiple different ways that can be done. Okay, so the direct and the indirect pathway, they begin at the cortex and they go through the striatum to reach the GPI SNR. The direct pathway will directly go from the striatum to the GPI SNR. And as we can see, this is a GABAergic pathway. Okay, so next, the indirect pathway will go from the cortex again to the striatum, but after the striatum, it will not directly go to the GPI SNR. It will go through the GPE, through the STN, and then finally to the GPI SNR. So as you can see, from the striatum to the GPE, it's a GABAergic pathway. From the GPE to the STN, it is again a GABAergic pathway. But from the STN to the GPI SNR, it's a glutamatergic pathway. Okay, now that can be that definitely is slightly complicated to remember. The only actual concept you have to remember is the direct pathway is cortex to striatum to GPI SNR, and it is a stimulatory pathway, as in the output from the GPI SNR to the thalamus will end up being stimulatory. Okay, then the indirect pathway is from the cortex to the striatum through all these other structures in between, that's GP, STN, and then GPI SNR. And once this indirect pathway is stimulated, it is going to be inhibitory. So I for I, indirect pathway is going to lead to inhibition. Okay. So motor activity will be stimulated by the direct pathway and will be inhibited by the indirect pathway. The direct pathway is under control of dopamine through the D1 receptor. The indirect pathway is under control of dopamine by the D2 receptor. How dopamine works on D1 is it stimulates activity through D1 receptors and it inhibits activity through D2 receptors. So dopamine stimulates the direct pathway and inhibits the indirect pathway. Okay, so we can sort of begin to see how loss of dopamine might lead to problems, which we will see in disorders like Parkinson's disease. So again, we have understood what are the input nuclei, what are the output nuclei, what is the direct pathway, what is the indirect pathway, and there is something called the hyperdirect pathway. Here the cortex does not go through the striatum and it directly lands up providing information to the subthalamic nucleus, and from the subthalamic nucleus that information is passed on to the GPI SNR. The importance of hyperdirect pathway, whether it actually has a role to play in diseases, etc., is not exactly sure at the moment. As we saw, D1 is a direct pathway that is excitatory, and D2 is the indirect pathway that is inhibitory. Okay, but when it comes to basal ganglia, not everything is about Parkinson's disease. There are other diseases which are involved. So, yes, it does get slightly complicated. There are multiple circuits within the brain which relate to the basal ganglia. There are four important circuits. There's a motor circuit, there's an oculomotor circuit, there's a prefrontal circuit, or also known as an associative circuit, and there's a limbic circuit. And they all have four different components of the brain. They will involve some part of the cortex, some part of the striatum, some part of basal ganglia outside the striatum, and some part of the thalamus. Okay, so the one that we are focusing on in this lecture is the motor pathway. So as we saw, there's cortical inputs which go to the striatum. In particular, with this motor pathway is the putamen that go into the SNR GPI, that's the output pathway, and then finally into the thalamus. In the thalamus, the important nuclei which are important for the motor pathway is the ventro-anterior and ventrolateral nucleus. And similar pathways exist involving similar structures for all the other different circuits. Now, it has been found that particular circuits and particular nuclei are targeted in different diseases. The ones that we're focusing on in this lecture should obviously target the motor pathway. So, the ones that we care about particularly are PD and dystonia. But as you can see, there are some movement disorders like Huntington's and Tourette's which can target other pathways as well. Right. So once information is provided to the basal ganglia, it is processed and put out by these output nuclei to go elsewhere. The primary output that comes out of this basal ganglia goes to the thalamus and particularly to the VAVL nucleus as we saw in the motor circuit. But there are other collaterals that are provided out of these nuclei to other places. An important area where collaterals go are the PPN. Okay, but another important area where they can go is in the thalamus, the centromedian and parafascicular nucleus. The PPN stands for the pedunculopontine nucleus. Okay, so these are other important collaterals. So the collaterals to the CMPF or the centromedian parafascicular nucleus of the thalamus allows the thalamus to directly feed back and provide information back to the basal ganglia. There are also collaterals to the PPN and the tectum in the brainstem that are also part of the feedback system. But collaterals to the PPN will also project down and they will provide information down to the pons, medulla, and spinal cord. Right. So a few questions, you can provide answers to this in the chat box. So the hyperdirect pathway is represented by which of these following pathways? From the striatum to the GPI-SNR, from the cortex to the GPI-SNR, from the cortex to the STM, or from the striatum to the STM. Okay, so the hyperdirect pathway is from the cortex to the subthalamic nucleus directly. From the subthalamic nucleus, the information is then provided on to the GPI-SNR. Okay, so another question is, which is the predominant thalamic nucleus which is involved in the motor circuit? Is it the CMPF? Is it the MD, which stands for the mediolateral nucleus? Mediodorsolateral nucleus? The VAVL or the VIM VPL? So the answer is the ventroanterior ventrolateral nucleus of the thalamus. Okay, so next we will discuss about the movement disorders and what we should know about them. Just a basic brief overview. So there are multiple classification systems for movement disorders, and we don't really need to go into the details of these. This is just an outline of what they look like. So there's hypokinetic disorders, hyperkinetic disorders, some disorders causing ataxia, and there are particular motor neuron disorders. They can also be divided based on the pathophysiologic mechanism of the movement disorder which happens. So on that basis, they're divided into Parkinsonian syndromes, choreoabalismus, and dystonia. Another way of classifying them would be on the genetic and molecular biologic data into alpha-synucleopathies, tauopathies, polyglutamine disorders, and other disorders. Again, just really not important to know as a neurosurgeon, I would say. So for our purpose, we will classify these movement disorders into hyperkinesias, hypokinesias, and disorders with mixed hypokinesia and hyperkinesia. So coming to the hyperkinetic disorders, these are disorders where movement is increased or movement is exaggerated. So we're going to see some abnormal movement happening. So the most common disorder that movement disorder that exists is essential tremors. So apart from essential tremors, there are other different types of tremors as well. So tremors can be divided into action or kinetic tremors, which happen when you do a particular movement. They will not be seen without any particular movement. Tremors which happen at rest are called rest tremors, and tremors which happen when you hold a particular posture. You hold out your hand and you develop tremors. That's a postural tremor. So a common tremor which exists is with normal people having a postural tremor of a frequency of 8 to 12 hertz, and that is a physiologic tremor. Now, tremors have been found to arise from the motor circuit as we discussed, but this is because of a synchronized oscillatory signal. There is a signal which is abnormal happening within the motor circuit, and because of this, there are these tremors. Now, ET has been particularly found to be arising because of central oscillators in the thalamus. Now, is a tremor physiologic or pathologic? To figure that out, a thing you can do is just weight the limb, just put some weight on that limb. So, if you put some load on the limb, if the tremors decrease, then they are probably arising from from a central or abnormal origin. Your physiologic tremors will not decrease if you put a load on the limb. Another way to identify them would be to find out the frequency that we cannot do visually, but a tremor of a hand which is more than 11 hertz or less than 6 hertz is always going to be pathologic. An important thing to remember about tremors is any type of stress will increase tremors. Okay, but these stressors always just increase the tremor amplitude, but they do not as such change the tremor frequency. Now, there are a lot of tremor disorders, but there are 5 important ones that we should remember. That is, as we discussed, physiologic tremors are particularly postural tremors. They occur at a slightly higher frequency of 8 to 12 hertz. They're usually going to be symmetric, and an important thing to remember about them is that they decrease with age. Essential tremors, on the other hand, the most common tremor disorder is more of an action tremor. Okay, so it will be seen when you do some sort of an action about a similar frequency, but as we can see, it worsens with time. It mostly involves the upper limbs, but it can also involve the head, legs, or voice. The Parkinsonian tremor is more or less a rest tremor of a lower frequency of 4 to 9 hertz, and more importantly, it involves the thumbs and the distal hands. So, and there's a specific pill rolling quality type of tremor which can happen with Parkinsonism. Cerebellar tremors and rubral tremors are two very low frequency tremors. Both of them are predominantly action tremors, which have high amplitude, so they can be a little difficult to distinguish. But cerebellar tremors are limited to action tremors. Rubral tremors can also be postural or rest tremors. Right. We'll just discuss what the definition of some of these other movement disorders are. Choreas basically are it's basically like just imagine somebody dancing. So it's random and complex involuntary movements, and that flits from one body part to different body parts, and they will move across multiple contiguous joints. On the other hand, athetosis will be a slow and undulating movement, while balismus will be a large and sudden movement. There's also something known as tardive chorea or tardive dyskinesia that happens particularly with your dopamine blockers, such as your typical antipsychotics. And akathisia is a feeling of restlessness. Myoclonus happens when there's a sudden and involuntary movement, but it is not like a balismus. Okay, so this is a much lower amplitude. It is it's basically like you've just been delivered a shock. And if there are multiple myoclonus, they do not flow into each other like chorea would. Myoclonus can be positive or negative. Negative is when you have a drop in the tone suddenly. So as we all know, asterisks is a negative myoclonus. Another type of hyperkinesia is a tic. So a tic is basically any sort of brief movement. It might be a action or it might be some vocal activity that happens. That is, before that tic, you're going to have a feeling of discomfort that will keep on building until the tic finally happens. So, and a hallmark of tic is that they are temporarily suppressible. It is possible to suppress them up till a certain point. So that is why rather than an involuntary movement, it's actually considered a semi-voluntary or an involuntary movement. It is slightly between voluntary and involuntary movements. A common area where tics are found is Tourette syndrome. So Tourette syndrome is basically motor and vocal tics happening before the age of 18 years. An important criterion is that there should be multiple tics and they should happen for at least 1 year, and with time they must evolve. Now, usually Tourette syndrome starts at 5 to 6 years of age, and apart from just tics, you can also get other psychiatric disorders along with Tourette's. So you can get ADHD, OCD, and an important, well-known feature of Tourette's is self-injurious behavior. There are also stereotypical movements that can be seen in hyperkinesia. So these are movements that actually looks like some sort of a useful action, but doesn't actually end up being useful. So again, these can be semi-voluntary or properly involuntary. So commonly these would include facial grimacing, just staring at lights, making some repetitive sounds, or other stereotypical movements like arm flapping. These are typical of autism. Right. So coming to our hypokinesias, like technically, hypokinesia means a decrease in the movement amplitude, while bradykinesia means a decrease in the movement velocity. Particular proper bradykinesia syndromes include gait freezing, stiff person syndrome, and neuromyotonia, and we're not going to be discussing these in detail. The bigger disorder we're concerned with includes both hypokinesia and hyperkinesia, and these are Parkinsonian disorders. Parkinson's disease has four cardinal features. There is a rest tremor, there's a bradykinesia, there's rigidity, and there's postural instability. Parkinsonism, on the other hand, is basically the presence of bradykinesia with any of the other three cardinal symptoms. So, to say that somebody has Parkinson's disease, you have to have these four cardinal features. But just bradykinesia with any of these other features would be considered as Parkinsonism. Now, coming to Parkinson's disease, Parkinson's usually is going to present within the fifth decade of life, and after that, not within, it will present after the fifth decade of life. The onset of Parkinson's before the age of 50 is considered as young onset Parkinson's disease, and the onset of Parkinson's before the age of 20 is considered juvenile onset PD. The earliest symptom in most patients with PD is going to be rest tremor, and particular things about PD tremor is that it is mostly going to be distal rather than proximal, and almost always it would be asymmetric. A symmetric rest tremor is going to be very unlike PD, as we will see. Another important aspect of PD is the very well-known Parkinsonian gait. So there are multiple different aspects of the gait. Important facts to remember are shuffling of feet. Arm swing can be decreased on one or both sides. There is going to be a stooping of the posture. Whenever they turn, it breaks up into multiple steps, and they turn en bloc. The body and the feet remain aligned when they're turning. There are also two important concepts when it comes to Parkinsonian gait. There's festination and retropulsion. Festination, as you can see over here, they look like they're chasing the center of gravity. Retropulsion is, if you give them a backward tug, they're not going to be able to recover from that. They will end up falling backwards. Right, so Parkinsonian disorders or Parkinsonism can be divided into there are at least 5 different disorders which resemble Parkinsonism. Apart from PD, you also have dementia with Lewy bodies, multiple system atrophy, progressive supranuclear palsy, and corticobasal degeneration. So when it comes to Parkinsonian disorders, there are particular different features that can help you differentiate between these different disorders. As we've already discussed the 4 cardinal features of PD. But apart from that, with dementia with Lewy bodies, it's in the name. You're going to get dementia. It's a very characteristic feature. Probably begin with that. Apart from that, you also have hallucinosis. But a feature which will differentiate it from PD is there is no resting tremor in DLB. Multiple system atrophy, on the other hand, there are 2 different types. There's a Parkinsonism type and a cerebellar type. The cerebellar type characteristically has cerebellar ataxia, and so it's quite easy to differentiate from PD. The Parkinsonism type, on the other hand, it is symmetric, and as we saw, PD is quite characteristically asymmetric. So that is one way to differentiate MSAP from PD. Apart from that, there are usually no tremors in multiple system atrophy, the Parkinsonian type. Apart from MSA and DLB, 2 other important differential diagnoses could be PSP and CBD. PSP again has symmetric Parkinsonism and the characteristic features of PSP, that is gaze palsies and bulbar symptoms. In CBD, again, an important aspect is dementia, but it can be slightly difficult to differentiate from PD because there is a resting tremor and there is some asymmetric features. But they characteristically have features known as alien limb phenomena, where it looks like one of their limbs is just involuntarily acting out. So that can help you differentiate it from PD. Another important disorder which has mixed hyperkinesia and hyperkinesia is dystonia. So in dystonia, you have abnormal simultaneous co-contraction of both the agonist and the antagonist. So because both the muscles are contracting, you get these abnormal postures and movements that arise because of this. Now, dystonia can be focal or it could be generalized. And some examples of focal dystonia, which involve the neck, include cervical dystonia, the eyelid, which would be blepharospasm. It could involve the voice also, leading to a spasmodic dysphonia. It could involve your hand, known as the writer's cramp. So usually dystonia is worsened by a voluntary movement, but sometimes this particular trick, a sensory trick, can help you relieve dystonia, and this can help you identify that the patient might have dystonia also. This is also known as Jess antagonist. So this is when you touch a particular body part, and that can help you relieve dystonia temporarily. Not seen with all patients, but with some patients it might work. Right. So let's see if we can answer these questions. Which of the following is not a cardinal feature of Parkinson's disease? Resting tremor, postural instability, bradykinesia, and motor fluctuations. Right, so the answer is motor fluctuations. We saw there are four cardinal features of Parkinson's disease: resting tremor, postural instability, bradykinesia, and the fourth one would be rigidity. Motor fluctuations is not a cardinal feature of Parkinson's disease. Now, which of the following would be false? A hallmark of tics is that they are temporarily suppressible. Weighting of the limb reduces the physiologic tremor. Multiple myoclonic jerks will not flow into contiguous joints. And Tourette syndrome should occur before the age of 18. Excuse me. Yeah, so the correct answer is weighting of the limb reduces physiologic tremor. That is one of the ways we identify a physiologic versus a pathologic tremor. Putting any weight on the involved limb should not reduce a physiologic tremor. All the other options are correct. Tics should be temporarily suppressible. Multiple myoclonic jerks should not flow into contiguous joint, otherwise that would be chorea. And Tourette syndrome should occur before the age of 18. Right. So coming to the last section for today, that is why to surgically intervene in these patients and how it should be done. So we'll discuss three particular disorders, that is Parkinson's disease, dystonia, and essential tremor. And these are the three disorders that we frequently do uh, lesioning or DBS for. So we'll discuss this in a slightly little bit more detail. So Parkinson's disease, the most common well-known treatment for Parkinson is obviously dopamine. Dopamine is very good for treating bradykinesia and rigidity, but it does not work so well for tremors. A very good reason to consider surgery for PD then does become tremors. But apart from tremors, another good reason is motor fluctuations. Now, motor fluctuations are a phenomenon which happens because of the treatment of PD. Okay, it is a phenomenon which arises out of dopamine. So when you give dopamine, there's something known as an on-off phenomenon. On is when the symptoms are reduced by dopamine, and when the dopamine action wears off, you get the off period where there's no effect of dopamine and the normal symptoms of PD return. Now, motor fluctuations are basically you get unpredictable on-off times. Your on times become shorter, your off times become longer. Apart from that, you also get dyskinesias. You get some abnormal movements which happen because of extra dopamine which is present. Right, so that's a very good indication for surgery in Parkinson's disease. Now, what is actually happening in PD? Now, as we know, the main problem lies within the motor circuit, as we have already discussed. Now, it has been found in PD that there is actually increased spontaneous activity in the output nuclei, like the STM, the GPI, and the SNR. And as we know, these are these two of these nuclei are frequently targeted in DBS, STN, and GPI. There's also been found to have for there to be decreased activity in the GPE. Now, all of this is usually happening because there's a loss of dopamine in the striatum, and this leads to increased indirect pathway output. But a more recent concept is that rather than the changes in firing rates of the nuclei, there might be some other abnormalities that are more relevant. What could these abnormalities be? A really important one is abnormal oscillatory discharge patterns. There are also burst discharges and abnormal interneuronal synchronization, but if you have to remember one thing, it is abnormal oscillatory discharge patterns when it comes to the recent concept of how PD works. So it has been found that there are increased oscillations, particularly in the beta range of 10 to 25 Hertz, that have been found in these nuclei, STN, GPI, and SNR. Right? So that is within the basal ganglia, but there could be pathology even outside the basal ganglia. So a dysfunction of the pedunculopontine nucleus has been found to be responsible for gait and balance problems in PD. And the dysfunction of the cerebellar output pathways is responsible for tremor in PD. Now, when it comes to dystonia, there are very limited treatment options. There are, even with medications, there are only anticholinergic agents and benzodiazepines. But apart from anticholinergic agents and benzodiazepines, there's really not much else you can do with medications. You can also give Botox if it is a localized dystonia or a focal dystonia to the particular muscle involved. But a very good treatment option with dystonia turns out to be surgery. Now, what happens in dystonia is that it also does involve similar motor networks as PD, but the primary treatment nucleus for dystonia is going to be GPI. The pathology might lie in the basal ganglia, in the cerebellum, or even in the cortex. So similar to what we have in PD, similar things are happening with dystonia also. Again, an important thing to remember is abnormal oscillatory activity. But apart from this, you can also have other dysfunction. There is an entity known as dopamine responsive dystonia, which is happening because of altered dopaminergic transmission in the striatum. And it actually responds quite well to levodopa. There might be other problems also, like the cholinergic interneurons might be affected, or there might be an increase in the activity of the direct pathway, which might be causing dystonia. But currently, the important thing to remember is abnormal oscillatory activity. Problems can also lie in the cerebellum, and cerebellar changes can induce changes in the basal ganglia output and vice versa, but they could also be involving the cortex. Right, so there are changes which have been found in the SMA, in the singular motor area, in the premotor cortex, and as we can see everywhere, there's increased excitability and there's reduced inhibition. And that has been found to be an important pathophysiologic mechanism in dystonia. Coming to essential tremor, as we have discussed multiple times, is the most common movement disorder. There are multiple treatments for essential tremor, actually, unlike dystonia. It responds very well even to small amounts of alcohol, but that is not a recommended treatment as such. The medical treatment also includes beta blockers and primidone. These are the first line drugs. Apart from that, you also have multiple other second line drugs like benzodiazepines, gabapentin, topiramate, clozapine, clonidine, and methazolamide. So that is why for essential tremor, surgery is not a first line treatment, even a second line treatment. It is indicated only for those patients who have medication refractory essential tremors or have disabling side effects because of these essential tremors. Now, the pathophysiology of essential tremor is again the same idea, abnormal oscillatory activity. But with essential tremors, and as we have seen with tremors previously, an important area of this activity would be the cerebellum. Ultimately, the pathway involved is going to be the same cerebello-thalamocortical pathway, but an important area of problem is the cerebellum. Right. So how does the surgical treatment work? So there are particular targets which are very well known by now. But mostly with these movement disorders, we're targeting the sensory motor territories of the basal ganglia nuclei. As we saw, within the basal ganglia nuclei, there are at least 4 different circuits, and the ones we want to target for movement disorders are the sensory motor territories. Now, when it comes to GPI, if we target the sensory motor territory of GPI, it is able to treat PD, but apart from PD, it's able to treat dystonia, tardive dyskinesia, hemipallismus, and chorea. An important aspect to remember about PD and GPI is that it treats the bradykinesia, the tremor, and the rigidity, but it does not treat the other aspects of PD. On the other hand, ablating or stimulating the STN is able to manage Parkinsonism and dystonia. But for dystonia, a more commonly used target is going to be GPI. Neither STN nor GPI are going to work very well for gait and balance problems in PD. So they're a slightly newer target for gait and balance problems for PD is pedunculopontine nucleus. For essential tremor and Parkinsonian tremors, ablation of the cerebellar recipient portion of the thalamus, not the cerebellum itself, but actually the part of the thalamus which receives the cerebellum recipients. Okay, that actually is an effective target for treating these tremors. Now, how do these surgical treatments work? More importantly, how does DBS work? Now, the full form of DBS is obviously deep brain stimulation, and the the most common idea we would have with that name is that it works by stimulation. Now, there is definitely stimulation which takes part. So, DBS for movement disorders particularly relies on high frequency stimulation. That is, it has to be greater than 100 hertz. Stimulation at lower frequencies actually does not work for movement disorders and might actually even worsen symptoms. Now, lesioning and DBS were found to have similar effects. So it was thought that maybe DBS, by using this high frequency stimulation, might actually destroy some areas or might inhibit some areas and might work by an inhibitory mechanism. But does not work that way also. So a common idea one might have is that if you put a lead into the STN or into the GPI, you're using high frequency stimulation to directly inhibit the nucleus. But it does not work that way. So it was found that stimulating the STN actually altered the GPI firing patterns rather than altering the STN firing patterns. This is because it was found that DBS does not affect the cell bodies. It affects the white matter fibers instead. And these fibers, for example, if you're stimulating the STN, the white matter fibers around the STN will be affected rather than the STN itself. So these include the STN projections and the pallido-thalamic projection. That is why the GPI firing patterns are altered rather than the STN firing patterns. So how it actually works is, rather than targeting a particular abnormality, what DBS does is that it targets the downstream targets of whatever nucleus you're stimulating. So it disrupts the abnormal activity that is going to be transmitted from the stimulated nucleus to the downstream nucleus. So it blocks that transfer. Because it blocks that transfer, it allows the relatively intact parts of the circuit to try and compensate and resume that normal functioning. So we'll just discuss that again. Basically, DBS, if you are stimulating the STN, it is not going to affect STN firing as such. It is not going to do that. It does not affect cell bodies. Right? So it is going to affect the white matter fibers around the STN. So it is going to affect the fibers going from the STN to the GPI, for example. So instead it is going to alter the GPI firing patterns. Because you're not able to transmit information from the STN to the GPI, that abnormal activity will not be propagated. So that allows the normal parts of the basal ganglia and other circuits to take over and try to resume normal functioning. Right? So that is how currently it is thought that DBS works. So these effects don't actually happen immediately and they can take some time. So rather than deep brain stimulation, it has been suggested that it should be considered to be deep brain neuromodulation. Right, so a few questions. Which of the following abnormalities is currently considered the most significant to explain Parkinson's disease? Increased firing activity in GPI and SNR, decreased firing activity in GPE, abnormal oscillatory discharge patterns, and burst suppression patterns. Right, so if I had to say the one thing you should take away from this lecture, okay, there are definitely multiple things you should take away from this lecture, but if you were to take away one important thing, it is abnormal oscillatory discharge patterns. That is the current pathophysiologic mechanism for PD, and that is what we are also trying to target with DBS. The second question is, which of the following about the mechanisms of DBS is true? DBS works at low frequency stimulation. DBS works by stimulating the nucleus targeted and hence directly replacing its activity. The action of DBS is immediate. DBS blocks transfer of information from the stimulated nucleus to its targets. Yes, so the important current idea of how DBS works is that it blocks the transfer of information from the stimulated nucleus to its targets. It does not do anything to the nucleus which is being stimulated itself, but affects the information being transmitted from that nucleus to its downstream targets. Right, so that is all for today's lecture. So next week we'll discuss more about how exactly DBS is performed and what is the use and the side effects and what are the complications which happen with DBS or movement disorders. If there are any questions, you can put them in the chat box and I'll be glad to answer them.